we are going to go through the talking mannequins. And in particular, the talking mannequins, they are about the assessment of unwell patient, okay? The talking mannequin are mainly about assessment of unwell patient, yeah? So we're gonna be looking at an ABCDE algorithm on how to assess unwell patient. And then you look at different common scenarios, okay? Such as the asthma, anaphylaxis, okay? We'll look through those ones. But so the key is in the beginning, we focus on looking at an approach to an assessment of acutely unwell patient. So in order for us to use that approach, of course, we have to identify that the patient is unwell, and then we will use the ABCDE algorithm. Now, generally, the talking mannequins, they are used to assess such situation, but there are some of the scenarios where the patient is stable and we do not need necessarily to go through ABCDE because we do have time to take the whole history and then examinations, then diagnosis, and then management. Okay, good. So, general approach to a talking mannequin. Now, as I said, there are two types of talking mannequins. Some patients are stable, some patients are unstable, yeah? So there are two types, stable patients. If there are stable patients, okay, then we just take the whole history. We are looking for things like the blood pressure moderately okay, 100/70, saturations 97 or above, heart rate within normal. Yes, there is a high temperature because there is a problem, okay? There is a problem, but the patient is relatively stable that we can take a history from this patient. Of course, it's not only about the observations, it's about how the patient looks in front of you. If your patient looks unwell, despite satisfying the observations, then you should use an ABCDE to assess the patient, okay? The patient is feeling unwell. Things like an acute limb ischemia, where the patient has got a leg pain, okay? The observations are stable, and how does the patient look like itself? Does it look stable or looks well? Then of course we don't have to follow an ABCDE because we do have some time where we can take the whole history and then go through the whole examinations to get to exactly a cause of the problem and discuss a management. So if the patient is stable, we do not need to follow the ABCDE to assess the patient. We follow our usual approach, that is history taking. You take the history taking and complete the presenting complaint, the past medical history, the ICE, the effects of symptoms, and then of course, we do examinations, yeah? As usual, that may include observations and then targeted examination, depending what is the problem. And then of course, after that, we discuss a diagnosis and then discussing management, which would include both investigations and the treatment. If the patient is unstable, unstable patient, then we have to use the ABCDE approach to assessing the patients. We have to use the ABCDE approach. If the patient is unstable, the patient is unstable if the vitals are unstable, or the vitals looks abnormal, let's say, the abnormal, low oxygen, low blood pressure, high heart rate, high respiratory rate, okay? But not only that, you also have to look at the patient. Sometimes, even if the vitals are stable, but the patient is very, very unwell. Doctor, I can't breathe, I can't breathe, I can't breathe, please help me. Doctor, I'm dying, I'm dying, I'm dying, I'm dying. Help me, please, doctor, help me, okay? So even if I'm having a normal blood pressure, a normal heart rate, I can tell that there's something wrong in here. I need, of course, to use an ABCDE to assess this patient. So the patient is unwell, if he symptomatically is unwell, or if, of course, the vital signs are abnormal, or maybe a combination of both, which means when we approach the patient, we will look at the monitor. We look at the patient, glance at the patient, how does it look like? We also look at the monitor, and then we decide this is unwell. I am using ABCDE approach to assess this particular patient. Okay, good. Now, we do have many scenarios that, of course, we need to have a look in terms of, how to approach them. Yeah, as you can see on the screen, many scenarios that we need to have a look. So what is the main task for us today? The main task for us today is assessment of unwell patient using the ABCDE algorithm. And usually when we are using, of course, when you're assessing unwell patients, examiners are interested to see how you apply the ABCDE. Examiners are interested to see how you apply the ABCDE. Any scenario you'll be given, whether it's an asthma, whether it is an acute bleed or anaphylaxis or an acute heart failure, okay, whatever the scenario, you see, it has to fit into an ABCDE so that when you use this algorithm, you will be able to identify unwell patients and manage them. It's important to say that the ABCD approach is not there to get the diagnosis. It is there to stabilize the patient. So what happens in this particular case, you assess the A and manage the A, you assess the B, manage the B, assess C, manage C, assess D, manage D, assess E, manage E. It's important to say A is more important than B is more important than C is more important than D, and D more important than E. It's better to think it that way, because sometimes candidates, when they are assessing the patient or using the ABCDE approach to assess the patient, what happens is they think, oh, this is anaphylaxis. I must give adrenaline before giving oxygen. Which one is more important? I must give IV fluids before I assess for B, because here there is no problem with the breathing, okay? Because there's no a problem with the breathing, okay? So we have to stick to the ABCDE in assessing the patient, okay? We have to stick to that. So let's start. So you can pass these stations without getting the diagnosis itself, as long as the application of ABCDE, of course, is accurately and you know how to apply it on an unwell patient. So we will start with A, airway. How do we assess airway when we identify the patient is unwell? Well, by speaking to the patient, yeah? Hello, Mr. Brown, how are you doing? Doctor, I can't breathe, I can't breathe, I can't breathe. Please help me, doctor, I can't breathe. Okay, so we look at the monitor, we look at the patient. Of course, regardless what the monitor shows, patient says he can't breathe, he's dying. This is an unwell patient. So A, the patient is talking, which means the airway is patent. So what do? We simply verbalize, and this we verbalize. We say, since the patient is talking, his airway is patent. Since the patient is talking, the airway is patent. Okay? So who are you telling? Are you telling an examiner in here, or you're speaking to yourself? Ideally, you would be telling your team. Okay? Ideally, you'll be telling your team. So in this particular case, what you would do is just verbalize it. The examiner will be able to hear that you've assessed the airway. What if you assess the patient? Hello, Mr. Brown, can you hear me? Can you hear me? And the patient is not responding. The patient is unresponsive. Okay? The patient is not responding and the patient is unresponsive because he's unconscious for some reason. Then what would you do? Of course, you need to assess the GCS. Yeah? So the common scenarios, like a patient has hypoglycemia, he's going to be unconscious with hypoglycemia, and he's not going to respond when you say, hello, Mr. Brown, how are you doing? There's no response because the patient is unconscious. Then you have to assess the GCS. Yeah, we need to assess the GCS now. So we're going to say, okay, so since the patient is unresponsive, okay, I will assess the GCS of the patient. So in this particular case, you would assess the Glasgow Coma scale of the patient. And if the Glasgow Coma scale is 8 or less, you would indicate that you need to call anesthetist to intubate the patient because the airway is compromised. The GCS of 8 or less, the airway is compromised. You would call anesthetist in this particular case. So we have two scenarios here in our assessment of the airway. Okay. We have two scenarios. We have got a patient that is responsive. We have got the patient that's unresponsive. Okay, so if the patient is unresponsive, which is this is our case in this situation. Okay, hello, Mr. Brown. Hello, Mr. Brown. Quiet, no response. Sometimes we may get a help from the examiner who may tell you, doctor, the patient is unresponsive. So, okay, since the patient is unresponsive, I will assess the GCS. Then you're going to assess the GCS of the patient. We will speak a little bit later on how to assess the GCS. Okay, I will assess the GCS of the patient. When you assess the GCS, if it's 8 or less, the airway is compromised, you call anesthetist to intubate the patient. Okay, good. So that's it. A. We have assessed A and we have managed A. In a situation where the patient is responsive, hello, Mr. Brown, can you hear me? Doctor, I can't breathe, I'm dying, I can't breathe. We simply say, since the patient is talking, the airway is patent. We have assessed it, we don't need to do anything. The airway is patent. Okay, then we move on to the next step, which is B. How we assess B? Try to talk to the patient throughout. When assessing unwell patients, yes, we have got a talking mannequin. Yes, it's not a real patient, but remember, you're being assessed for interpersonal skills as well. You're being assessed for interpersonal skills. So you have to maintain that, patient-doctor relationship, good bedside manners. Okay, so you talk to the patient in there. Okay, Mr. Brown, remember what you have just done. I can't breathe, I can't breathe. Okay, let me look at your monitor. Okay, Mr. Brown, let me look at the monitor. I can see that your oxygen is low and your breathing rate is high. Try to use layman's term. Yeah, I can see that your breathing rate is high and your oxygen is low when you look at the monitor, because in this particular situation, there will be a monitor for you to look at. Okay. Now, I need to give you some oxygen. Can you tell me, do you smoke? Have you ever been diagnosed with the COPD? No. So I'm going to be giving you high flow oxygen. Now in here, unless there is a documented COPD, we have to give you a high flow oxygen, 15 liters per minute via a non-rebreathing bag. Okay, a high flow oxygen, 15 liters per minute via a non-rebreathing bag. Okay, that's what we would give you the patient. Now we don't just talk verbally, which is a mistake of the many candidates. You just simply talk, and then once I say it, then things would change. The oxygen would go up. No, we need to do things for real. Do things for real. So which means you need to go and take the what? Take a non-breathing bag, okay, and apply on the patient face. And when you apply on a patient face, ensure that you are not rough. It's a real patient, it's an elderly lady, it's an elderly man. So you have to be very gentle and explain while applying the mask on the patient, okay? And you explain it as well while applying the mask on the patient. Okay, Mr. Brown, so this is just an oxygen to help you breathe better, okay? So apply it gently, not rough, okay? Good. So do it for real. Where will you find the non-breathing bag? Of course, everything is in an emergency trolley. Yeah, an emergency trolley is equipped with anything you need in an emergency. So you find the trolley and you get your non-breathing bag mask. Of course, you need to know how a non-breathing bag mask looks like. Okay, you need to know how a non-breathing bag mask looks like, so that you can identify it. There will be other masks in there, not only one mask. Okay, good. Now you have given oxygen to the patient. Okay, and then the window has opened for a very focused, very targeted history. In here, you're gonna have to ask some few questions. You will also need to look around. Yeah, we are assessing very quickly. Look around, what is around the patient, any clues, and then a very focused history, very targeted history. It's not the long P3 Maftosa history, social history, occupation, and those type of histories. It's very targeted. What's a presenting complaint? It is a shortness of breath. Then we'll be able to do the odd para, the onset. Okay, did your shortness of breath come on suddenly or gradually? Okay, when did you start experiencing shortness of breath? Okay, is it getting any worse? Progression. Okay, aggravation, anything that makes it worse, relieving, anything that makes it better. Associations is our differential diagnosis. Okay, associations, we're going to ask for a differential diagnosis. Now, the common shortness of breath is a very common presenting complaint. So you have to know about a few common differential diagnoses that include 1, a pneumonia, 2, a pulmonary embolism, 3, an MI, 4, the asthma, 5, the COPD. Okay, so they are the common ones. And of course, things like pneumothorax, okay, cardiac tamponade also need to be, brought into the picture. But then it's very difficult to ask specific questions about pneumothorax, specific questions about cardiac tamponade. Okay, but in our history, in our asking, the examiner needs to be able to hear you covering the pulmonary embolism as a shortness of breath. Okay, heart failure from pulmonary edema, an MI on its own, the pneumothorax, the asthma, the COPD, okay, the pneumonia, okay, because the shortness of breath is a common presenting complaint in an unwell patient. And therefore, you need to know to cover this differential diagnosis. And when you do the differential diagnosis, make sure you're organized, you're not jumping back and forth. The common problem in here that the majority of the candidates would know what is the diagnosis, sometimes even before they start, because the patient may tell you, doctor, my asthma is killing me. My asthma is killing me. Please help me. It is my asthma is back. Okay. This is my asthma, doctor. You know, it's not responding well. So it gives you diagnosis the patient from the beginning. Now, that makes you blind in some way that you talk only about asthma, but examiners are looking how you would assess this unwell patient, okay, in real life. You may have a pneumothorax, though the patient thinks it's an asthma. So if you just go in there and start giving salbutamol or other things before assessing the patient well, then you may fail this particular station. So we have to take a proper history, but it's very targeted about the shortness of breath and a few, life-threatening differential diagnoses. Yeah, we go asthma. You can ask directly, have you been diagnosed with asthma? Okay, have you been diagnosed with COPD? Okay, are you having any chest pain for pulmonary embolism? Any chest pain? Okay, any pain in your calf? Any recent traveling? Any recent maybe long flights, long journeys? Anyone in your family was ever been diagnosed with clots in the legs or the lungs? Okay, anyone in your family was ever been diagnosed with clots in the legs or the lungs? Okay, so any heart problems, any high blood pressure, high blood sugar, because of the risk factors of an MI. That's it, we're enough. Do you take any other regular medications? Okay, no. Pneumonia here, put the questions together. Any cough, yeah? Any shortness of breath, okay? So make sure the DDs, the common ones, are covered. Allergies, check the patient wristband, okay? Do you have any allergies, okay? The talking mannequins, they will have a wristband. You need to go and have a look on the wristband, yeah? So pneumonia, ask a cough, ask for a fever. Are you running any temperature, any cough, any shortness of breath, okay? And look at the monitor. Sometimes we would say, are you running any temperature? No, but when you check the monitor, the temperature is higher. So you have to look at the monitor when you ask the patient for a fever. Then, of course, there is a specific history. All these are scenarios, assimilated scenarios. So there will be a specific history. If it's an asthma scenario, there will be a specific history about asthma. If it's anaphylaxis, about anaphylaxis. If it's a pneumothorax, in the pneumothorax, maybe there was a trauma, maybe how he sustained it while riding a bicycle, while exercising. So there will be a specific history of each scenario. So you have to ask questions there about specific history. If it's asthma, then you need to ask more. How long have you got the asthma for? What treatment are you on? You also have said to do what? You have to look around because you may have some equipment. For example, medications of the patient, yeah? Are there any medications, any inhalers around the patient, any medications, tablets, steroids around the patient? If you see them, you don't just look at them and say, okay, they are his medication. We ask them, are these your inhalers? Yes. Do you take any other medication other than this? Yeah. If it is a blood transfusion reaction, what you may find, there is a blood transfusion bag. Patient is on blood transfusion bag. Okay. Other scenarios, maybe it's post-operative scenario. Yeah. Is there any catheterization? Are there any catheters around? Are there any drains? Are there any patient's notes around for you to look? Any drug chart that you may want to open and have a glance? Okay. Any vomiting bowls in there where the patient is vomiting? So in other ways, you just have to glance around and have a look. Okay. Just glance around and have a look. There may be some equipment relevant to your scenario. So it's a very quick here. It's not a long prolonged. What may happen while you're trying to figure out this targeted history? The patient may deteriorate. The patient may become even more and more unwell. Doctor, I can't breathe. Please help me. I can't breathe. Please help me. Please help me. Okay. And then what you find that candidates in this situation, they panic. When they panic, then they go and start giving nebulizer salbutamol. It only means speed up. You have to speed up a little bit more quicker. So what you do, you reassure the patient. Okay, just give me a few seconds. Okay, just a few seconds. Ask 1 or 2 questions. Okay, I also need to examine you. You should also go now and do your examinations more quicker. But you don't jump at that point in time and start giving nebulizer salbutamol because the patient has told you, I've got an asthma. Then you just jump. You didn't even perform a chest examination. Okay, so to reassure, just give me a few seconds. Okay, so I'll be with you just a few seconds. Good. So What else you see around? You may see an emergency trolley where all your equipment are kept. You don't need to do anything here, okay? You just have to know what is around you, yeah? So what can you find in an emergency trolley? You find everything you may need: the glucometer, the IV cannulas, the oxygen mask, nebulizer mask, any medications, fluids bag, medication, beta blocker, digoxin, diuretic, adrenaline, mention them, because they are there for you to do things for real, okay? They are there for you to do things for real. You want to give a nebulizer? Please, you need to go and take salbutamol from an emergency trolley. Take a nebulizer mask, then apply on the patient face, of course, then apply the mask on the patient. Then you may be told, okay, assume your nebulizer has been given. But if you just talk verbally, you don't take the equipment or the medication, this is where you find that oxygen did not improve, and you find the candidate experience of an exam is different, okay? So you need to make sure that you do things for real. So they are kept there for you, and they are there for you to be used. So what happens when we take this quick focused history and we look around? If there is nothing, then there is nothing. If there is something, then we ask about it. Okay. After that, we perform a chest examination or a respiratory examination. Okay. Now, in here, the common mistake is not actually doing a proper respiratory examination. Candidates, what they would do, they demonstrate to an examiner what they would do instead of performing an examination. Okay. What they would do is supposed to expose the patient to do an examination. They would do examination on top of the clothes, no exposure. Okay. Palpation, instead of proper performing palpation to pick up for tenderness, they will be kind of touching the patient. Any pain anywhere, any pain anywhere, any pain anywhere. So in real life, you wouldn't pick up local tenderness in such a way. Percussion, the same. What they would do in percussion, I'll be tapping you on your chest. It's like just to show that, okay, yeah, percussion have done it, okay? But you haven't done it. You wouldn't pick up a hyperresonance or downness on percussion by doing this. That's quick, okay? It can't be done that way. It needs to be done properly. And you must speak to the patient as you assess the patient, okay? So in here, we are talking about, okay, Mr. Brown, I just need to examine you now, okay? I just need to expose your chest. Is that okay with you? Yes, doctor. Then you expose the chest. Now here comes in when exposing the chest. Don't take the whole cloth of the patient and pull it away and throw it somewhere. You have to treat the patient with dignity. So you expose only the chest, which means you roll, okay, the cloth down, okay? Because the patient is in a hospital gown. Just roll the gown down, okay? And expose only the chest. Then you have a look. Okay, what I need to do, I'll be pressing in the chest now. Bear with me. You press it genuinely, like somebody who's looking for tenderness. Any pain anywhere? No. Any pain this side? Any pain this side? No. The talking mannequin can talk. That's why it is called what? A talking mannequin. It would reply you back. Okay, good. Percussion. I'll be tapping on your chest. Remember, it is comparison. So you percuss on one side, percuss on another side, percuss on this side, percuss on another side. What is important in this particular case is the technique as well. Your wrist need to move when doing percussion. Yeah, your wrist need to move. Okay. Not forgetting percussing on the basis, but you do it like somebody's looking for hyperresonance, somebody's looking for downness on percussion. Yeah, good. Next is auscultation. I need to listen to your chest now. Take a deep breath in and out for me. Now remember, the talking mannequin is breathing in and out. What's a common mistake? People moving stethoscope before the mannequin finishes a deep breath in and out. So you cannot move a stethoscope in the middle of the one breath. So you have to listen to one, wait for deep breath in, out, then you move the stethoscope to the next, in, out, then move the stethoscope to the next. So the way you move your stethoscope is not synchronized to the patient breathing. That tells you again, you are not really auscultating, which is a problem in here. So make sure we do proper respiratory examination, okay? It doesn't take very long. Okay, Mr. Brown, I just need to be examining you now. I just need to expose your chest, okay? Good. So when you expose the patient, don't make an animated inspection where you turn, you look your head like this, you turn, you do like this, and then you look like this. You are wasting your time. When I expose the patient and I start doing palpation. During palpation, will I not see the chest? You'll be able to see the chest. During percussion, will I not see the chest? You'll be able to see the chest. So we don't spend any time on inspection. The moment you expose the patient, okay, I just need to examine you now. Okay, I need just to expose your chest. So bear with me. You expose and you begin your palpation immediately. Almost like not doing this part, because whereas I'm pressing, I am looking. Okay, of course you're looking carefully. Then of course you do percussion in the same way, and then auscultation. All this time you're looking. If there is anything, you'll be able to see. So do not stop and very slowly looking there, very slowly looking like this, and then looking like you're trying to demonstrate how you would do inspection. No, you just look with the eyes and move. Yeah, almost skipping this inspection part, because I will see during palpation and percussion, no wasting time. Do not forget to auscultate on the basis, because you have got scenarios of pulmonary edema, for example. Okay, good. Now, what did we say in the beginning? It is assess and manage. Assess and manage. So let's recap. What did we do at B? Okay, at B, we spoke to the patient. Yeah, we looked at the saturations and the respiratory rate. Then we say, ask the patient, oxygen was low, respiratory was high. Do you smoke? And COPD said, no, we gave high flow oxygen. To cut everything short, we looked at the monitor only at the oxygen saturation and respiratory rate. Because we are at B, it's not time to start talking about heart rate or talk about temperatures or talk about blood pressure. When you're at B, you only look at oxygen saturation and look only at the respiratory rate. If oxygen is low, then you give high flow oxygen. Before giving high flow oxygen, you simply ask any COPD. No. Then you do things for real. Take your mask and apply on the patient face and say you can be giving high flow oxygen. Done. Then what else have we done? You're taking a focused history of the presenting complaint, shortness of breath. If it's a chest pain, you do the Socrates. Do not be blinded by patients telling you the diagnosis of a chest pain. Okay, then we go through the past. You look at the wristband. Fever, look at the monitor. We have taken this focused history. You also have to look around. There may be equipment. If there are, you ask the patient about those equipments. Okay, then you perform chest examination, respiratory examination. So this is all assessment. So our assessment is a quick, very focused, very targeted history, plus the examination of the chest, that's respiratory examination. So we have assessed that. What do we do next? We manage the breathing. We have assessed the breathing, how we manage the breathing. Okay. So for example, if there is a wheeze on auscultation of the chest, then it doesn't matter whether this is an asthma or this is an anaphylaxis or it's a COPD. What do you need? You need nebulizer salbutamol, 5 milligrams. The only difference is if it is a COPD, then you wouldn't give oxygen, you wouldn't give nebulizer salbutamol via oxygen, yeah, driven via oxygen. You would give it on air, okay? So in asthma and anaphylaxis, you give nebulizer salbutamol, okay, driven via oxygen. So which means the same time you are giving nebulizer salbutamol, at the same time you are giving oxygen. Because if you give only nebulizer salbutamol and you stop giving oxygen, what would happen to saturations? It would drop. Okay, but in COPD, if you give nebulizer salbutamol with oxygen, then what would happen? You will cause CO2 retention and the patient will go unconscious. Okay, so here, if it's asthma or anaphylaxis, yeah, you're suspecting. That's why we need that quick focused history. Otherwise, we'll do things wrong in there. Okay, then you say, I'm going to give you nebulizer salbutamol, okay, driven via oxygen. Now, go do for real. What you're going to do, you take a nebulizer mask, take a salbutamol from where? From an emergency trolley, apply, you change the mask from the non-breathing bag mask you applied at, in the beginning to a nebulizer mask. Then you take salbutamol, and when you take salbutamol, then they'll be able to tell you, okay, assume that is given. If you didn't say it would be driven via oxygen, in asthma and anaphylaxis, saturations will drop. So you're going to be now start panicking. I've given nebulizer salbutamol, but saturation is dropped. Yes, because it has to be driven via oxygen at the same time. Okay, good. So it's important to say that I'll give you nebulizer salbutamol 5 milligrams driven via oxygen. Good. So That's what we have done. What else do we need? If there has been abnormalities on the B, or examination of the chest, such as low oxygen or crackles or wheeze, then we need the respiratory tests. Okay, that's an ABG and the chest X-ray. How do you do it? Try to speak to the patient all the time. Yeah. Okay, Mr. Brown, I need to arrange a chest X-ray for you, and I also need to arrange a blood test called an ABG to check for what? Oxygen in your blood. A blood test to check for oxygen in your blood. Okay, so that is B for us. Now, this looks a lot, but otherwise in here is explanation. So what practically do I do at B? I look at oxygen and respiratory rate only. Okay, then I give high flow oxygen. Okay, then I take a targeted focused history. I perform a respiratory examination. Whatever I find, I manage. If, for example, there was crackles, then they wouldn't be needing me to manage immediately. I can't manage crackles immediately. Okay, it is an infection. Okay, I have to do it at the end because I need an IV line, which I do not have. I need an antibiotics, but maybe, it's not yet ready. So if it was a wheeze, then there's something to manage immediately. If it's something else, you may not need to manage it immediately. Okay. What else did I do? ABG and chest X-ray. Good. So we finish the B. We go to C, circulation. Okay. Now try to speak to the patient all the time. Yeah. Okay, Mr. Brown, I just need to assess your blood pressure now. Just look at the monitor again. Your blood pressure is low. Your heart rate is high. Okay. And I can see on your monitor. So you're looking at the monitor. Your monitor shows a sinus tachycardia. Okay. Now that simply means your heart is working faster than usual. Or the monitor shows an atrial fibrillation. Okay. It simply means an irregular heartbeat. Yeah. Can I feel your pulse? So you can feel the pulse when you look at the monitor here, not for long. Okay. Your monitor shows a normal sinus rhythm. So everything looks normal from your heart point of view as of now. As of now, and everything looks normal from the heart point of view. Okay. I'm just going to press you on your chest to check for a capillary refill. So you press on the sternum for a capillary refill. 1, 2, 3, 4, 5. You release. Okay. Don't worry about the results. The examiners may give you the results and say, okay, capillary refill is normal or capillary refill is prolonged. But if they don't give you the result either, you just have to move on. Skin color, I can see your skin color is normal, Mr. Brown. Okay. Skin temperature, you touch it, the hands and the feet of the patient. Okay, let me feel your hands and the feet. Then you touch the hands of the mannequin, touch the feet of the mannequin. Then you say, the skin temperature is not cold to touch or hot to touch. Yeah, your skin temperature is not warm to touch or cold to touch. Yeah, warm, it is a sepsis. Yeah, cold, of course, hypoperfusion. Let me listen to your heart now, Mr. Brown. Then you listen to the heart. If the cause is clear, like for example, on the chest, there is a wheeze, everything suggesting asthma, then you just auscultate on one position on the apex. That's enough. If you think, you look at the monitor, there's an atrial fibrillation. What does it tell you? There is a heart problem. Okay, there are heart problems in here. You have to auscultate on all the 4 areas. Yeah, so where the cause is straightforward, you are able to identify it via the history and the chest examination, and you feel there is no heart problems in here, we're going to be examining only on one position and usually on the apex. But if there is suggestions of heart issues, like an atrial fibrillation, for example, then you have to auscultate all the 4 areas. We are assessing the circulation. Okay? We are assessing the circulation. Hello, Mr. Brown. Okay, let me just look at your monitor again. I can see your blood pressure is low, your heart rate is high. Okay, your monitor shows a normal sinus rhythm, which means just everything looking normal at the moment from your heart point of view. I'm just going to be pressing you on your chest. Bear with me. Okay, for a few seconds. 1, 2, 3, 4, 5. Okay, so your skin color looks normal. Yeah, just going to touch your hands and your feet. Okay, so I can see that, of course, your skin temperature is not warm or cold to touch. Now I need to listen to your heart. Okay, then you go straight in one position. Okay, so I also need to do a test, Mr. Brown. I need to do an ECG. Sorry, I need to do an ECG. That is a tracing of your heart. Yeah, to arrange an ECG tracing of your heart. This is assessment of our circulation. Okay, that's how we assess our circulation. Okay, we may go ahead where you're suspecting bleeding, for example. Yeah, there is a bleeding. We might need to do an abdominal examination. We might need to do, genital inspection. Yeah, external genitalia inspection. Yeah, situations such as post-operative patients, patients who are post-operative. Okay, patients who are suspecting maybe upper GI bleed or perforated peptic ulcer. You have to, of course, perform an abdominal examination as part of your circulation. Where is the bleeding? Okay, because it's part of C circulation. So in here, you do a full lead ECG, then we proceed to abdominal examination. I now need to examine your tummy as well, Mr. Brown. So you expose. Inspection, almost always we skip it because if there is anything, it's clear we see it from the beginning. The reason I'm saying this, people waste a lot of time by trying to demonstrate their inspection, looking right, looking left. You can look there very quickly and move on, okay? So we inspect it and palpate, yeah? I'll be pressing gently on your tummy. Let me know if there is any pain. When you palpate, ensure that you palpate everywhere, yeah? Including the loin, okay? Ensure you palpate everywhere, palpate on the loin, suprapubic, all parts, all the areas you palpate, okay? Now, Mr. Brown, you bear with me. I need to have a look on your private area, yeah? You need to have a look on your private area. Just bear with me. Then, of course, you inspect it, yeah? We're talking about situations where there is a PV bleed, the catheters, is urine draining, so the urine output is good, okay? Is there any melena? If it is upper GI bleed, there is melena, okay? Any rashes, allergy, anaphylaxis may cause rashes in the legs, in the groin. So we need to do these things. So if it's a bleeding scenario, okay, created, or it's a post-operative scenarios, we have to do an abdominal and external genitalia inspection or examination. Okay, so which means there are situations like asthma, we would assess our circulation here and leave it there without having to start the abdomen and the rest of the stuff. Okay, but in things like, for example, post-operative bleeds, internal bleed after an operation, then we would need to do an abdominal and a private area examination. So that will be our complete assessment. Yeah, that will be our complete assessment. Then we have to manage. We manage the circulation. Okay, so what are we managing? If it's an anaphylaxis scenario, for example, then we will do straight away, and the management of, say, first thing we do is adrenaline IM. Okay, first thing we do is adrenaline IM. Every other scenario, we're going to do what? An IV line. Okay, now in here, examiner wants to see which cannula. You have to pick up the cannula. From where? Emergency trolley again. Pick up the cannula, and examiners may ask you, what's the gauge of the cannula? Okay, but anyway, the gauges of the cannula are written already on the cannulas themselves. So you have to know, yes, we know that maybe the orange cannula is the biggest, the gray cannula is big, and so I'll pick the gray cannula, I'll pick an orange cannula, but you have to know the gauge. The examiner wants to know the gauge of the cannula. Now, it's not the cannulas that you're theoretically going to mention, it's the cannulas available in an emergency trolley. So there may be no orange cannula or gray cannula. So amongst the cannulas that you have, you need to be able to pick up those cannulas, to pick up the biggest, yeah, cannula of what is available. Yeah, so we're doing everything for you. So you have to go and pick the cannula. Yeah, and the examiner may ask you what's the gauge of that cannula. So put an IV line. Then what's next? We send the bloods for routine blood test. Okay, for routine investigations, for routine bloods, group and save where necessary. Cross-matching for units. We are talking about bleeding scenarios in here. You have to group and save and cross-match for units. Yeah, otherwise routine investigations. Full blood count, UNEs, LFTs, glucose, okay, is what we're talking about. So put an IV line, you send the bloods, give IV fluids if needed. You see, if needed. We do not always give IV fluids, okay? Again, we do for real. Give IV fluids. You need to pick up the fluids you need. And the examiner may want to ask you, how much fluid will you give and at what rate? How much fluid will you give and at what rate? So we need to be able to know what fluid and how much. Go pick it up from where? Emergency trolley, and hang it on the stand. Let's do for real. Pick up the fluid and hang it on a stand. That is our task. Okay, good. Then how do we give the fluid? So our fluid management, we discussed yesterday when talking about IV fluid prescriptions. Okay. Why do we give you fluids? The three main things we discussed was resuscitation. So we give bolus fluids, and then we said the deficit, where there is dehydration, and then we said the maintenance. Sorry, maintenance fluid. So here we are resuscitating. So we give you fluid start. Start means as fast as possible. 1 liter normal saline in both arms, as fast as possible. This is in all bleeding scenarios where the blood pressure is very low and the patient is bleeding. Okay, we have to do that. And yeah, IV fluids, 1 liter in both arms. 1 liter normal saline, 0.9% in both arms as fast as possible, or we simply say start. So start means as fast as possible. Anaphylaxis, we need aggressive fluids. Bleeding, we need aggressive fluids. So that's why we do fluid start, 1 liter in both arms start. Fluid challenge. A fluid challenge, we're giving 500 ml of normal saline over 15 minutes. 500 ml of normal saline over 15 minutes. Okay, the blood pressure is low. Usually it's better in elderly patients. Maybe they're in hospital with different problems. Okay, and there could be heart issues as well. So instead of aggressive fluids, we do a fluid challenge, 500 ml of normal saline over 15 minutes. If the blood pressure doesn't improve, then you repeat a fluid challenge again over 15 minutes, yeah, and see for the response. So like a little bit careful with the fluid, not to worsen other issues like heart failure. So as an example, in hospital-acquired pneumonia, you may go aggressive, you may do a fluid challenge. That depending on how low the blood pressure is, of course, judging the situation. Yeah, urine sepsis, depending how the blood pressure is, if it's borderline 100 over 80, around there systolic 100, then of course, yes, you can do a fluid challenge to push up the blood pressure a little bit more. So what is a fluid challenge means? 500 ml of normal saline over 15 minutes. We can apply them in a hospital-acquired pneumonia. The urosepsis depend on the situation, so I'll remove it from here, okay? But a hospital-acquired pneumonia can do fluid challenge and another fluid challenge if it's not improving. What about asthma? Do we give you fluids? There are no fluid situation. We only give you fluids if the patient needs fluids. So if we're doing an asthma situation, we don't need to give you fluids. Hypoglycemia, we don't need to give you fluids, yeah? Postoperative pain, the patient is only in pain after an operation. If he doesn't need the fluids, he is able to take orally, do not give IV fluids. Okay, the heart failure, dangerous. You give IV fluids, in heart failure, the patient will die, will become unresponsive. So it's not always robotic giving IV fluids. If he doesn't need IV fluids, do not give IV fluids. Maintenance fluid. Is there situations we said yes, when do we give maintenance fluid? If the patient is new by mouth and is being planned for an operation. In this particular case, the patient has got an acute limb ischemia being planned, to go for an operation, and you're going to advise the patient not to eat or drink anything, which means you have to give them what? Maintenance fluid, normal saline, 1 liter over 12 hours. So we're saying in here, there is a resuscitation fluid and there is maintenance in our scenarios. So maintenance in here, new by mouth. So yeah, you're going to maintenance fluid. The other ones, it's a fluid start, aggressive fluid because they are bleeding, because they're in shock. Okay, and then fluid challenge, of course, in here, like in pneumonias, where we are afraid of worsening heart failure, and then there's no fluid situation. Don't give you fluids unless a fluid is needed. Okay, so in things like asthma, hypoglycemia, post-op pain, okay, heart failure, dangerous. You give you fluid, you fail that station in this particular case. Okay, so this is C circulation. What have we done under C circulation? Let's recap. We have looked at the monitor, blood pressure, heart rate, the monitor itself, sinus tachycardia, the rhythm, skin color, skin temperature, auscultate on the heart. Then we do a ECG, okay? If it is bleeding scenarios or post-op scenarios, we examine the abdomen, inspection and palpation only. We look at external genitalia, for catheters, for melenas, for rashes, okay, for PV bleed, okay, in women, and then management. If it's anaphylaxis, we would straight away the first thing, IM adrenaline. Okay, in all other scenarios, we would put an IV line, send the bloods, give IV fluids if needed, and we do it for real. Pick up the fluid, place it on the stand, and the examiner may ask, how quickly will you give your fluid? Okay, and we have discussed that the fluids, we can give aggressive, start, or as fast as possible in all bleeding scenarios and anaphylaxis, a fluid challenge in hospital-acquired pneumonia, no fluid situation, and there is maintenance situation. Now, you have got an IV line. What else you can do on C circulation? You give medication IV. You give IV medication, okay? You can give IV medication where you give IV medication. For example, in asthma, you may give hydrocortisone 100 milligrams IV, yeah? Hydrocortisone 100 milligrams IV. Good. Then we go to D, disability. What do we do first? We assess and then manage. Every stage is assess and manage, assess and manage, assess and manage. That's what you need to remember. Let's go to D. We have managed circulation. Now we go to D. Okay. How do we assess D? We assess the conscious level, we assess the PPUs, we assess the glucose. Then we review the treatment offered in A, B, and C and take necessary action. Okay. We review the treatment offered in A, B, and C and take necessary action. So let's have a look in your conscious level. Either we're going to use the GCS or AVPU. Okay. So let's have a look how to assess the GCS. AVPU, what does it stand for? A, the patient is alert. Okay. V, the patient responds to voice. P, patient responds to pain. And U, the patient is unresponsive. Okay. The patient is unresponsive. So if the patient conscious level is not reduced and the patient is speaking to you and is answering your questions, you simply have to say, on an AVPU system, my patient is alert. We're talking about scenarios such as asthma. He's talking to you, doctor, I'm dying, I'm dying. Heart failure, doctor, I'm dying, I'm dying. Upper GI bleed, doctor, I'm vomiting. Okay, or post-op bleed complications, anaphylaxis, talking, doctor, I have this rash, I can't breathe. Okay, hospital-acquired pneumonia, he's talking to you, confused. Okay, urosepsis, I'm not feeling well. Post-op pain, I'm in pain. Okay, so these patients, they are talking to you, they are alert. So we simply say, on an AVPU system, my patient is alert. We don't have to go and do the Glasgow Coma scale in these particular scenarios because the patient is talking to you. If we feel that the Glasgow Coma scale is reduced, okay, then we have to do a Glasgow Coma scale, which means in situations such as the patient is drowsy, like for example, postpartum hemorrhage, patient has lost a significant amount of blood and is drowsy. Yes, we need the GCS. Hypoglycemia is unresponsive. Yes, we need to do the Glasgow Coma scale. But you have to assess the patient in front of you. Does he look like he's drowsy? Is he unresponsive? Perform the GCS. Okay, the Glasgow Coma scale. Now, if you are to do the scale, how do we do it? Try to keep it simple to the basics. It may be difficult on the mannequin because the mannequin can talk, but there are some things a mannequin can't do. Cannot raise the arm, cannot follow the commands, open the eyes and then open it. Okay, so there are some things that may be difficult. So how are we going to assess the GCS? Yeah, so we need the verbal response, we need the eye response, we need the motor response. So what we do in this particular case is we ask for verbal response for TPP, orientation in time, in place, and in person. Okay, so Mr. Brown, can you tell me what time of the day is it? Do you know what time of the day is it? That easy. We need it in the morning, afternoon, or at night. The common mistake to say, do you know what's the time now? We're not asking for the time now. It's time of the day, morning, afternoon, night. Do you know what the time of the day is it? P, orientation in place. Do you know where you are? Where are you now? P, orientation in person. Can you tell me your name, please? Okay, orientation in time, in place, and in person. So do you know what time of the day is it, Mr. Brown? Okay, can you tell me where you are? Do you know where you are at the moment? And can you tell me your name, please? Orientation in person. Then for the eye response, we'll keep it basic school, okay? Can you open your eyes for me? Yeah. Can you open your eyes for me? Motor response. Can you lift your right arm for me? Or can you lift your left arm for me? Avoid the things such as lift your leg, okay? So can you lift your right arm for me? Now, basically, if the patient can obey command opening the eyes, which means the same as motor obeying command, Okay, but we try to break it down so that it becomes simple for the learning purposes. Can you open your eyes for me, please? He opens his eyes. Can you lift your right arm? He lifts his arm. Now, the mannequin cannot follow your commands. So what you may find, the examiner may tell you, okay, the patient is opening his eyes. Okay, can you lift your right arm for me? The patient is lifting his right arm because it cannot do these movements. Yeah, good. Sometimes you have no answers. If you have got no answers, the mannequin is not replying to any of this because he's drowsy, because he's unconscious and unresponsive. Then what do? You apply for the pain. So you're going to apply the pain. So the first thing is going to be what? Voice, the verbal stimuli, voice. Try to speak, try to get the answers to verbal response, eye response, and motor response. If you by talking, you don't get the answers, then you apply pain. Always talk to the patient. Okay, Mr. Brown, I'll be applying some pain on your chest, bear with me. And you try to apply pain on the sternum. Yeah, so bear with me. So you apply pain on the sternum. Because remember, the one that may give you the findings is an examiner. So this is why by warning the patient, you're also warning the examiner, I'm about to apply pain. Okay, so Mr. Brown, bear with me. I'll be applying some pain, of course, on your chest. You apply pain, the examiner may tell you patient is opening eyes and localizing to pain. For example, patient is opening eyes and localizing to pain. So eye response is what? Opening eyes to pain, which is 2 on a Glasgow Coma scale. You need to look at the table, okay? And is localizing to pain, okay? What is localizing to pain? That is 5, okay? But the examiner didn't tell me the verbal response because the talking mannequin can talk. So you don't get the findings for the voice. Did it talk? No. So the verbal response was none. So which means it's 1. So localizing to pain, which is 5. Opening eyes to pain, which was 2. There was none voice. There was no voice, no verbal response, 1. So the Glasgow Coma scale of the patient is 5 plus 2 plus 1, 8. And therefore, the GCS of this patient is 8. And why did we say? You have to call anesthetist to intubate the patient if the GCS is 8 or less. Okay, good. Proper understanding of the GCSE, that of course will be taught during the course. If you're attending here in the initial phase, for those that are doing the exam next week, you've already been taught on how to do the Glasgow Coma scale properly. Okay, good. So we have done the GCS there, which is the first part of our D disability, assess the conscious level. And we said we don't always do the GCS. If the patient is talking to you, you simply say, on every PU system, my patient is alert. Then you assess for the pupils. Go in an emergency trolley, take a torch, shine light in both pupils. Okay. Of course, they will not react to light, but just shine. Don't worry about the results. The next one is take a glucometer and talk to the patient. Mr. Brown, I just need to prick on your finger to take some blood so I can test for your blood sugar. Yeah, I need to prick on your finger to take some blood so I can test for the blood sugar. You go to the emergency trolley, take a glucometer. Then they may give you the finding, glucose is normal, or give you a value of glucose. So the problem comes in when you only try to talk, to make everything verbal, to turn a practical task into a theoretical viva. You want to just be exchanging words with an examiner. No, go and pick up the equipment, talk to the patient, then they'll give you the findings. Take a torch, shine a light. If they give you findings, they give you findings. Okay, go and do a GCS. If they give you findings while it's doing GCS, you'll be given findings. Okay, but you can't ask there what's the GCS of the patient. Expect to be given the GCS. Okay, good. Or what is the glucose? Yeah, you can't ask that. You have to do it for real. So what's the last thing? So you assess the conscious level, the pupils, and the capillary glucose. Then we review the treatment you have offered in A, B, C, and take necessary action. Okay, and you take a necessary action. So if it is an asthma, for example, what did we do at the A? A, the airway was patent. At the B, we gave oxygen. We gave nebulizer salbutamol. At the C, we gave hydrocortisone because with an IV line now, we give 100 milligrams hydrocortisone IV. Now, what's the response of the patient? B, saturation. Saturations have improved or not improved. Okay, the blood pressure was normal, didn't drop in asthma because there's no reason to drop. So we're now looking, all the treatment we have given is for asthma. Oxygen, nebulizer salbutamol, hydrocortisone. Has the patient improved from saturations and respiratory point of view? No, is still unwell. If still saturations are low, okay, then of course we need to reassess the patient. How are you going to reassess? Reassess the treatment you've offered in A and B. So let's look at an asthma situation. Yeah, we will have to look at the what? Look at the saturations. Okay, Mr. Brown, let me have a look. So your saturations are still low. Yeah, it's 92%. Okay. Are you still having short of breath? Doctor, I can't breathe. I can't breathe. Please help me. I can't breathe. So it's still symptom-wise, it's still short. He still has shortness of breath. Saturations are still low. Then I can say, okay, give me just 1 second. I need to listen to your chest. You just auscultate on one position, or there is still wheeze. So what I'm going to do, I will step up now, Mr. Brown. I'll be giving you magnesium sulfate, 2 grams IV over 20 minutes. So I have reassessed by talking to the patient, looking at the saturations, and auscultating just on one position, not wasting time. There is still wheezy. We're moving on to magnesium sulfate, 2 grams IV over 20 minutes. Let's do it for real. It's not a theory. Let's go in an emergency trolley, take the magnesium sulfate of the patient and explain to the patient. Then they may tell you, Dr. Azumu is done. Okay. If it's anaphylaxis, what did you do at C? You gave adrenaline. Has the blood pressure improved? No. You can repeat adrenaline. If it's hypoglycemia, you have given glucose, it's still low. You can repeat IV glucose. So our purpose in here is reassess and take necessary action in here. So what is the D disability? Check the GCS, the conscious level. So check the conscious level, either doing the GCS or the AVPU system. Check the pupils of the patient. Check the capillary glucose, okay? And review the treatment you offered A and B. And here is, another scenario of bleeding. So patient is suspecting is bleeding. Either it's an upper GI bleed, is vomiting blood, okay, or is postoperatively. He had the repair of aneurysm or any internal operation and is bleeding, so it's got internal bleed. What do we do at C? Okay, let's go back. We get an IV line. We're going to give IV fluid aggressively because it's bleeding. That's what we said. So when we reach D, we review. Has the blood pressure improved? We give aggressive fluid. No, it has not improved. So what are we going to do? The blood pressure is still dropping. It's less than 90 systolic. We don't have time to wait for cross-match. So what do? We give you group O negative blood. So we reassess here for a blood transfusion. Yeah. So I can see that the blood pressure is still less than 90 systolic. Yeah. It was 80. It became 83 only. Moved up by 3 units only. Yeah. 83 over 50. Okay. And now you can say, okay, so I can see that there is no adequate improvement to the blood pressure, okay, or adequate response, okay, with the IV fluids. The blood pressure is still less than 90 systolic. So what I need to do now, Mr. Brown, I want to give you a group O negative blood, yeah, to help push up your blood pressure, whereas we are waiting for cross-matching blood, okay? Now here you may get questions, okay, how much of the blood you're going to give? Well, to begin with 2 units of blood to give the patient, and then reassess. You might need to give more blood to the patient, depending how much blood has been lost. Now, this is important that we're going to reassess at D, okay, and not to stay in one position, okay, and not to stay on one position. What I mean not to stay on one position is, again, we take an example of asthma. What people do, I'll go back to B, okay? What people do, you are here at B, I'll give you salbutamol 5 milligrams. How are you feeling? Doctor, I can't breathe, I can't breathe. I'll give you hydrocortisone, 100 milligrams. How are you feeling? Doctor, I can't breathe, I can't breathe. I'll give you magnesium sulfate, 2 grams. How are you feeling? Doctor, I can't breathe, I can't breathe. I'll give you aminophylline this. So there is no an ABCDE that is happening, and there is no giving time for the medications or for the treatment to work. As a result, then you're stuck in here. Eventually, you give everything. How are you feeling? Okay, doctor, I feel better. Thank you very much. Yes, it's an asthma. You have given all your medications, feeling better. Okay, thank you now. We're going to admit you. I'm going to talk to my seniors. But where is the ABCDE? It stopped at B, the moment in nebulizer starts. Similarly, if the problem is at C circulation, I'll give you IV fluids, or let me look at the blood pressure. The blood pressure is not improving with IV fluids. Okay, I'm going to give group O negative blood now. Are you improving on cross-match? I'm going to give you blood. So you're stuck. Oh, the blood pressure is now back to normal. Thank you very much. I will admit you now. I will talk to my seniors. So there is no D, there is no E. because you're stuck in one position and the brain says, keep giving treatment. As long as the patient becomes well, then you would pass. No, we say the examiners are looking how you would assess the patient, how would you follow A, B, C, D, E. So at what stage do we assess the patient? We reassess our ABCs at D, okay? If at D, for example, we have checked the glucose and the glucose is low, we will give it IV glucose. And we're gonna give it some time, at least 5 minutes or so for the IV glucose to work. Then in the meantime, I will need to assess you further, Mr. Brown. I need to assess for E. So I'll say, okay, now I need to assess for E, yeah? So I need to have a look at your tummy. Okay, any pain when I'm pressing on your tummy? No, doctor. Okay, bear with me. I need to have a look in your private area as well. Okay, all good. Need to have a look in your leg. Look and palpate in the legs as well. Okay, all normal. Now I'm gonna go back and say, okay, so some 5 minutes have passed. I need to recheck your glucose to see how, what is your blood sugar now. So you leave there to the next stage, you come back and reassess. Okay, you don't stay in one position, then your station will finish in that one position, and that will not be a good, of course, demonstration of an A, B, C, D, E approach. It wouldn't be a good demonstration. Okay, good. So once you finish D, you go to E. What is E? E is expose and examine the patient. If you haven't done the abdomen and external genitalia, it's time to do it. Let me have a look at your tummy. You inspect it and palpate. Any pain anywhere, and we say do not forget to palpate for the loin, suprapubic, periumbilical, epigastric area, everywhere you have to palpate. Let me have a look in your private area for me, please. Just bear with me. You look in here, you may find the catheters, you may find the melena, you may find rashes, you may find the different things. Then let me have a look at your legs. No any redness, no cellulitis. Palpate on the calf for any signs of DVT. Okay, good. The E has finished. If there was a treatment offered at D that need a review, you go back at D, need a review, and maybe repeat it, glucose again. Okay, the blood sugar is improved, the patient is stable. Now I can go to F, after stabilization, after resuscitation, which is further management. Now I can say, okay, so explain to the patient. What do we do? The patient has been stabilized. Everything was chaotic, everything was quick, but now it's time to explain to the patient exactly what is happening. Okay, Mr. Brown, I have assessed you now. You had shortness of breath, your oxygen was very low, you had wheeze on an examination of your chest, and that you have had asthma for a long period of time. Okay, I feel what you have is an acute exacerbation of asthma, which you were right when you said your asthma has come back. Okay, so that is the diagnosis we have given. Now, further management. What we need to do, we need to keep you in a hospital so that we can continue the treatment. We have to keep a close eye on you on monitoring. Okay, I have requested investigations for you, the chest X-ray, the blood, the ECG. We're going to wait for those investigations. Once they are back, I'll come back and explain them to you. Okay, I will also take a second opinion from my seniors. If they will suggest anything different from what I've told you, I will let you know. Now, what this means, please, common mistake in here is listing examiners as part of your management. Listing examiners as part of your management. So things like, okay, I will need to admit you, I will do the investigations, I will talk to my seniors, I will continue treatment, I will. So what you are listing seniors as part of your management. No, you have to list your own management, telling the patient your own management. At the end, you can say, I will also take a second opinion from my seniors. If they will suggest anything different from what I've just explained to you, then I will let you know any changes that needs to be done. Okay, but do not list the seniors as part of your management. Let's recap the ABCDE so that it remains clear in our brain. Let's go back to the beginning. So, assessment of unwell patient. A, how do we assess? Hello, Mr. Brown, are you all right? Are you all right? I can't breathe, I can't breathe. Since the patient is talking, the airway is patent. We have no issues with A. If there's no response, okay, I need to assess the GCS, your chest GCS of the patient, GCS 8 or less, you call anesthetist. A is done. B, look at respiratory and oxygen. Oxygen is low. Do you smoke? No. Give high flow oxygen. Do it for real. Everything, go do for real. Then your window is open, for a forecast history. You also look around for the equipment. That's B. Then what you do next is respiratory examination. What did you find? If there is a wheeze, manage salbutamol, nebulizer, driven via oxygen or on air. We do on air in COPD, via oxygen, asthma, anaphylaxis. Again, for real. If there's abnormalities, low oxygen, wheeze, crackles, what you should do? ABG, chest X-ray. How do we do these things? Always talking to the patient. Okay, Mr. Brown, I need to arrange some test for you, a chest X-ray or ABG. Circulation. It's okay to say, okay, Mr. Brown, I will assess your circulation now. That may help you to remind you're beginning this. Okay, and I can see your blood pressure is low, your heart rate is high. Your monitor shows an atrial fibrillation, which means a regular heartbeat. Can I feel your pulse? You check the pulse now. Okay, skin color, capillary refill. If the blood pressure is normal, there's no need of you wasting time checking capillary refill. If the blood pressure is low, then you're expecting a prolonged capillary refill, then you can check a capillary refill. Okay, otherwise skin color, you just look. Skin temperature, feel the hands of the turkey mannequin and feel the feet of the turkey mannequin. And you say the skin temperature is not warm or cold to touch. Warm is a sepsis, cold is hypoperfusion. Then you auscultate for the heart. If the cause is clear, auscultate in one position. If there's a possibility of heart problems, like for example in AF, the monitor shows an atrial fibrillation, then you need to auscultate on all the 4 areas. Okay, good. Full lead ECG, I need to do a tracing of your heart. And if it's a bleeding scenarios or post-operative patients, yeah, then you perform examination of the abdomen and external genitalia now. Then you go to manage circulation. So this is how we would assess our circulation. Then we manage it. You get an IV line, send the blood, IV fluids if they are needed. And we have discussed different fluids we would use. Do it for real. Pick up the fluid from emergency trolley, hang it on your stand. You have got an IV line, you can now give medication, if there is medication to be given. Then you go to D, assess the conscious level, either GCS or AVPU system. Take a torch, check for the pupils, glucometer for capillary glucose. Then review the treatment offered in A, B, C, and take necessary action. Review and step up to the next step. Okay, if it's normal, then you don't have to step up. Then what is next is E. What do we do on E? If you have not done abdominal examination, expose and perform abdominal, expose and examine the external genitalia, expose, look at the legs and palpate for the cuff. Okay, that is E. If the patient is stable, we have stabilized. We go to post-stabilization, further management. In here, you have a responsibility, okay, to explain what was wrong with the patient, what did you find on assessment to the patient, and what is diagnosis, and how you would manage further. It could be discuss management with an examiner. It could be discuss management with a patient. Okay, so we said, for example, in here, okay, Mr. Brown, I have assessed you. You had come in with shortness of breath. Your oxygen was low. You had wheeze on your chest. Okay, we have given you nebulizer salbutamol, IV hydrocortisone, and magnesium sulfate, and you have responded well. I suspect you have an acute exacerbation of asthma. So what we need to do further is we need to keep you in hospital. We need to continue the current treatment. You are taking nebulizers, okay, and you're on magnesium sulfate. We have requested investigation like bloods, chest X-ray, ECGs. We wait for those ones as well. And I'll take a second opinion from my seniors. Yeah, second opinion from my seniors. Okay, and if they suggest anything different from what I have just told you, I will let you know. We need these seniors last after you have outlined your own management. Okay, so this is how we would perform an ABCDE.